Good evening, everyone. I'm Dr. Mike Cromer, President of the Hillsborough County Medical Association. I'd like to welcome all of you who have joined us tonight for HCMA's first virtual town hall meeting. Throughout the last 3 months during the coronavirus pandemic, the HCMA has worked hard to provide our members with information and assistance that we thought would be beneficial. With this in mind, tonight we thought it'd be helpful and interesting to hear from some local experts and members of our own association about the coronavirus pandemic. We have titled this town hall meeting, What If, but What Now? And I will be the moderator, and I will be presenting questions to our expert panelists. And joining us in one room is Dr. John Sinnott, and in a different room, Dr. Doug Holt. Dr. Sinnott is the chairman of internal medicine at the University of South Florida College of Medicine and is an epidemiologist at Tampa General Hospital. Welcome, Dr. Sinnott.
Welcome, thank you.
And Dr. Holt is the health officer of the Florida Department of Health in Hillsborough County and a professor of medicine at USF College of Medicine. So glad that you could join us tonight, Dr. Holt.
Thank you, Michael. It's a pleasure.
Tonight, we will get a historical perspective on the pandemic. We're going to hear some up-to-date information about the virus, its transmission, possible treatments, and the short-term likelihood of developing an effective vaccine. We're going to explore how this viral outbreak has affected us here in Tampa and Hillsborough County and in the state, and will continue to affect us in the near future. Our panelists will be answering previously submitted questions, but if time at the end allows, we will accept a few more questions from our viewers. Thank you for those who submitted questions already. To submit a question during this webinar, please press the chat icon found at the bottom of your screen, then type in your question in the box at the bottom in the right column, and then press enter. Okay. By now, hopefully everyone who's going to be joining us has had a chance to sign on and be accepted. I would just like to start letting us know a little bit about each of you by having you panelists describe to some extent how has your professional life changed during the last 3 months. Dr. Sinnott, I'll let you go ahead and start.
I was minding my own business, running a department of internal medicine, but thinking I'd left much of my infectious diseases days behind. And I was actually in Asia over New Year's, and I know January 2nd, I heard about this odd virus in China. And I immediately became concerned about SARS. By the end of January, I knew we were going to have problems. And it's been extraordinarily busy with planning, preparation, emphasis on access and quality. So it really has changed what I do a lot. We've been focused a lot on research. Now we're focused a lot on taking care of critically ill patients and almost ICU patients.
All right, so previous to this, mainly in an academic setting, running a department, and now working in a hospital, caring for patients, and doing the epidemiologic studies that everyone's interested in. Dr. Holt, tell us a little bit about your professional life, both before and after. Before and right.
Yeah. Well, before, I call it BC, before COVID. You know, I was looking long-term. I lead a health department, 400 dedicated professionals that are really trying to make health, get everybody a little opportunity to get healthier. And so a lot of what we do is kind of long-term. I look out, how can we change behaviors? How can we provide some direct services? But it really was not, I would say, in an immediate, it was really sort of, we were taking the long-term vision of influencing a community. And, you know, very suddenly, I recall the first, I was Friday night walking I was sitting down. I thought I was going to have a quiet evening, and I got a call from a state epidemiologist, and, how you doing? I said, well, I'm talking to you at 5 o'clock or 7 o'clock at night on a Friday. I haven't talked. That's unusual. And she said, yeah, Doug, you got to one of the first cases in the state. So from there, it has been just, minute by minute, hour by hour. People ask me how I'm doing, and I say, well, just ask me in a few minutes and it'll be something different. It's full, it's lively, it's exhausting, but at times it is exhilarating.
All right. I believe it's the health department that and your staff that has been responsible in setting up some of the free clinics around our county. Is that not right?
I'm sorry, say that again?
I believe it is your staff and your department that has been important in setting up some of the free testing sites around the county.
Yeah, well, it has been a complete collaborative. We work with the county government. We're under the state of emergency. Our role is basically to contribute, and so the county has done the sites. The hospitals have stepped up with the staff. The city and county have provided support. My team has been there. It's really been a community effort.
All right. All of our lives have been affected, but I know we'd be particularly interested in seeing how you guys' lives have changed. Thanks for sharing that with us. Between the two of you, I don't know how many years of infectious disease experience we have, but quite a lot. And in your experience with what's your experience with other viruses and other pandemics that might have gone on in the last, 30 to 40 years, or even in this last 100 years in the United States, and compare some of those either in number of deaths or the economic effect. Compare those to the COVID-19 virus, if you will. Dr. Sinnott, go ahead first.
I think there was a massive pandemic in the 1880s, but there was not good record keeping. But the result of that pandemic was that people started keeping records. It started in Germany, and then the movement went to Great Britain and then to the US. The first really well-documented event we had was the Spanish flu in 1918. It arrived in the spring. It, of all things, originated at a pig farm adjacent to Fort Riley in Kansas. World War I was in full swing, and they were busy shipping troops off. And the original doctor who wrote an account of it said that he was seeing 10 patients a day, 20 patients a day, and the next day 200 patients. And he noticed that at least a fourth of them died in the prime of life, 18, 19 years old. He sounded the alarm, but because of the war and lack of effective communications, people really didn't know that. So they shipped the soldiers off to Philadelphia, Boston, New York, different ports. And that rapidly was transported to Europe in a very somber situation where, not well reported, but oftentimes a troop ship would lose a fourth of the soldiers to influenza on the ride over. And they would just dump the body over the side and write the name down. And they would report to the family that he was lost at sea. So, Germany wasn't telling us how many cases they had. We weren't telling Germany how many we had. Spain was neutral and said, hey guys, a fourth of our population just died. Have you noticed anything going on? And that's what got it the name Spanish flu, although they were definitely innocent bystanders.
Okay.
That's been the greatest pandemic to date. Somewhere between 50 and 100 million people died. It was a grievous disease with long-term side effects of photoconomos, encephalitis, Parkinson's, and things of that nature.
Okay, Dr. Holt, how about some more recent pandemics like the Hong Kong flu or SARS?
Yeah.
How these differ? How does this differ from those?
Yeah. The difference is, some of the things that we've dealt with, familiarity, the swine flu, the H1N1s, hepatitis A of recent, West Nile coming in, the Zikas and others. These were not pandemics. They're very localized. There were outbreaks, often affected in certain populations. HIV is clearly a pandemic, but the risk factors are not generalized. They're regarding behaviors, and we now have a very accurate labs, testing, and effective treatment. So this is completely beyond anything that I have experienced in my career, if you will, but looking back, the Spanish flu does tell us some things that we are clearly seeing, and personal space matters. Crowded places are dangerous. And if you get missed messages and you don't follow some directions, there are consequences, and prices were paid in some local parts of the country. Very different.
All right, so even though a much more modern era now, the things we took out of that pandemic over a century ago then was mainly that social distancing is important, large crowds are not good, and pay attention to the policies that are put in place. Okay. There's different theories about the origin of COVID-19. And Dr. Sinnott, speaking from someone who has actually been to the lab, why don't you kind of give us what you know as far as the origin of this virus?
Sure. The laboratory in Wuhan was designed with the assistance of the United States. One of the pathogens they specifically work with is coronavirus. Although we all have short memories, the number one threat, infectious-wise, to world stability is influenza, but the number two threat is coronavirus. China had wonderful flu facilities, so they wanted corona facilities. It's not a biologic weapons laboratory. It could be, but no one would try to make a biologic weapon out of an RNA virus, because what you start out with is not what you end up with. That wouldn't make any sense. The idea that it escaped from there doesn't make sense to me. It's at least 50 miles south of Wuhan, and it's a crummy road. So how that leads to 14 men getting sick at a wet market between December 10th and 12th doesn't make any sense. There's no evidence whatsoever that this is biologically engineered. There's no evidence that it was grown in a lab. There is no RNA sequence that corresponds to this. It's unique.
You said the wet market, meaning like a meat market. Could those animals have come somewhere near the lab? From somewhere near the lab?
That's possible, but I don't know why a virology lab, you need a BSL-4 lab for pathogens like this, absolute highest biosafety. They were visited and some suggestions were made how to improve it, but I simply can't imagine, this is built to American standards, operated to American standards, and the issues found were like food in the wrong ice box, things like that, not pouring sewage into the river or something.
All right. In this fight against COVID-19, what are some of your guys' opinions on the way that the United States and our state of Florida has handled this with some of the different policies that were put in place? Dr. Holt, do you have opinion on that?
Well, clearly, there are some things we have done well, and there's some things we haven't done well. I don't like to look back too far. It's kind of the blame game, but and what we have to deal with is the now. But clearly, I think the testing we did not do well. We were off to a slow start. We stumbled out of the gate. We've came up with a fairly complicated test and persisted to make it work. It's accurate. It's very good, but it's a challenge to administer compared to some of the other that the world has used. Now we're doing the opposite. We're sort of rushing to put a lot of tests that haven't really been validated out there for people to use and get tested, and that's creating, I think, some confusion. And got to say it, we are really a nation at war. Yet each state has sort of had to, fight its own battle. Haven't really had coordinated leadership from the federal government and support. So what I think locally, I think we've done very well, partly because we've had good relationships. Our medical community, the health departments, we're whether it's for hurricanes or whatever, we've had an established relationship. So it was natural to come together. The hospitals, put their competitiveness aside, stepped up. And in fact, at 5 o'clock, I was just on a call with all the hospitals and all the areas working on how to meet the challenge of all the long-term care facilities. So, and then, our public, our leaders did step up and initiated some early social distancing practices. The challenge I think we all face is that there is a lot of politicization on this, and social media. I'm not a fan. It certainly creates a lot of problems, and but I don't think we're not. There's other parts of the country that are much more extreme. So, I think I'm proud of so far what we have done as a community in responding, and the fight's not over.
All right. So the things we learned way back to the Spanish flu, the social distancing and staying away from large crowd gatherings, we did those fairly early on, and that definitely has helped. Dr. Sinnott, what are some practical ways that we, as not just as physicians, but as citizens, can do to protect ourselves? What do you feel is the recipe or the top 3 to 5 things that we can do?
Well, number one, just like the early days of HIV, we need to consider everyone potentially contagious. People can look fine and spread this virus by talking, coughing, or sneezing. No matter what you read, it is airborne for anywhere from 30 minutes to 3 hours. How do we defend ourselves? Number one, you would protect yourself with a mask to some extent, but the surgical masks often used really protect other people. So it becomes almost a social obligation to protect others to wear a mask. Secondly, there is literature out that people that have low vitamin D levels do not do as well with this virus. So probably 4,000 units a day is the dose that most people in infectious diseases would recommend. They would suggest also high-touch surfaces are going to result in the use of hand sanitizer, alcohol swabs, something like that, but almost religiously. Now, how would I break that down? 95% of the cases I talk to don't know where they got it. They have absolutely no idea, okay? Of that 95%, or outside that 95%, the other 5% probably got it by touching something or by fomites, and maybe 0.3% or less got it on an outdoor sport. So it's not a hardy virus, but it loves to spread inside person to person.
Okay.
Mike, if I may,
Go ahead.
I get asked this question a lot as well, and I kind of go back to first. Dr. Sinnott did it very well. You first know the enemy. It is a respiratory virus, and you've got to do what you can to not get exposed. So, keeping your distance, wearing the mask, both for others and yourself, and good hand washing. So. And it really comes down to situational awareness. Know where you are going, when you need to take those extra precautions. Maybe know where you shouldn't go. And so, I was driving home. I saw a sign, and it said, "Stay calm, stay kind, and stay safe." I like that.
Mm-hmm. Right. Dr. Sinnott, what about this COVID-19 virus makes it different as far as its virulence? Why it might have a higher, more mortality rate than other viruses that have come through our country? Is it something about it, what it does inside the body that makes it so dangerous?
Yes, in the same way that HIV was unique and presented us with previously unseen, unrecognized illnesses, we find ourselves with the same thing now. Somebody with a blue toe, for instance, someone with an unexpected stroke or MI. We now know that there's really two disease processes going on. Number one is an endotheliitis. There are ACE2 receptors on endothelial cells. They get infected and you have deranged blood clotting. So you have thrombosis, or with other patients bleeding. We're not sure why some do one and some do the other. Secondly, as your body begins to respond with the adaptive immune system, you run the risk of cytokine storm, where tumor necrosis factor activates not just interleukin-1 and interleukin-2, but it activates interleukin-1 through 16, all at the same time, which is catastrophic for the body, gives you renal failure, complicates the COVID with ARDS, etc. So there's really two pathophysiologies going on, and they don't occur at the same time. Usually the vasculitis is first, okay, and the cytokine storm is later.
With this mechanism of action and its multi-system appearance and presentation, what are each of your guys' opinion on the various treatments that are being studied? What's your opinion on, let's say, the remdesivir and other potential treatments? Dr. Holt, do you have an opinion on that?
Actually, I think I'd defer to Dr. Sinnott to begin with. He's on the front lines caring for the patients, and he has both. I certainly know some of the literature, but I think much of this is understood by the practicing physicians a whole lot better than I. But Dr. Sinnott?
No one really has the right drug. And there's an old saying in medicine that when there's not one treatment, there are many. And if you look, everything under the sun has been tried. Remdesivir is the most successful so far. It shortens time on the ventilator from 18 days on the average to 13. Now, this is the key reason that we run out of ventilators, is because the average stay on event is 3.4 days. Now, all of a sudden, someone is on it 6 times as long. That ties up everything. Remdesivir helps alleviate that. We've used it extensively. We've used high titer plasma infusions from patients that have recovered. The results there are more subtle. We don't see as clear-cut a response. We have probably at Tampa General right now 14 different studies. One of them is how do you prophylax healthcare workers? Another one is how do you treat people that are positive but not sick? And a variety of ICU therapies. So we're still looking. I think the great hope is the unique RNA polymerase that this virus has. And I suspect that long before a vaccine, somebody's going to use a platform similar to the therapy we use for hepatitis C, but rather using an anti-RNA polymerase compound that you would probably take like malaria medicine, either once a day, once a week as they refine it. I hold out much greater hope for that actually than a vaccine. Number one is the public is very skeptical about vaccines, which is, to me, an embarrassment. I don't get that. Secondly, in the American mind, people like to take pills. If somebody came to your office and left without a prescription, they'd be a little annoyed. So, like I say, I think the pill will get early, wider acceptance and perhaps cover as we develop a vaccine. Developing a vaccine is a very complex process. You have to watch people after they get a vaccine because in vaccine development, for example, with the polio vaccine, they were vaccinating people for 16 weeks before they realized they were actually giving them before they realized they were giving them active poliovirus. So there's many ways mistakes can be made with the vaccine. Like I say, I'm cautious about that. I'm more optimistic about a medical approach initially.
Having been involved in pharmaceutical research and vaccine research in the past, any idea on any timeline of an effective treatment or an effective virus? Any short-term hope?
I would imagine that next spring we'll have some idea of an oral agent or perhaps a medication given parenterally, either IM or IV. And in 2 years, probably an acceptable medication. Everyone hopes for a vaccine. Most vaccines are sometimes fail, patients don't respond, they don't show up for a follow-up booster dose, etc. And with this very active anti-vaccine movement, I'm troubled about the future of a vaccine.
Dr. Holt, a while back you alluded to testing and how that has been one of the slower things to come about. Let's talk about the testing because a lot of our members are doing testing in our office. They know that people are tested when they go to the hospital. There's the free clinics around. Let's not talk about the antibody testing right now, but the antigen testing. Tell us the difference between those. What's the false negative among them? What's the best that we can hope for as far as doing testing right now?
Okay, yeah. Well, I mean, I think, you must begin with what you're ordering the test for, what purpose. Again, I think Dr. Sinnott taught me, hey, if you don't know what you're going to do with the results, maybe you shouldn't order the test. In the diagnostic world, the PCR is a very good test if collected and processed properly. and sent to one of the, a reputable or a standard lab that has available. I mean, these are tests that you obtain deep nasopharyngeal swabs. You're looking for not the live virus, but the RNA. And it is then processed by machines that we use all the time. The viral respiratory panel is very standard in the hospitals and even in some of the outpatient clinics. The tests should be run, the labs that we have, certainly the state lab, Tampa General and Baycare, have state-of-the-art labs, Quest, LabCorp, but there are labs that have run tests that aren't, they don't have the quality standards. And I think you read in the paper where people have to reject large numbers of tests that were collected, particularly some of the drive-through places. These tests really don't, the virologist will tell you there is no false positive or negative. They either tell you there's virus, they detected RNA or not. The issue really then becomes, if it was properly sampled, and also whether the patient indeed had symptoms or not. So the negative tests that can result in a PCR generally are those that perhaps are too early in their illness. The collection process was not adequate. Possibly even too late in the illness if you don't, it's already moved down into the lung. The version of that test that's available and that people have probably experienced is this rapid test. It's available in 5 to 15 minutes. The one that is most widely known is this Abbott test that's the White House uses. These tests were designed, for point of care testing for symptomatic people, not screening of asymptomatics. So you'll see a high amount of false negatives in this test, and that's not good because in fact, and even if it's a positive test, it really should be verified with the nasopharyngeal swab. I think you mentioned the antigen test. These really aren't quite ready for practical use. They are still being refined and certainly not available widely in any practical sense. They do have, I think, a future that would be very useful in a outpatient clinic or any other point of care testing, and that you could get a rapid a check for someone who's symptomatic to see if they actually have the active infection. It may, ideally look at a rapid flu test, same type of things. Rapid flu test is problematic only because the virus changes and sometimes the antigens are different. But coronavirus is a much more stable virus. Welcome Dr. Sinnott to share his experience with actually, again, using these in a clinical setting.
Reflecting on what you said earlier then, Dr. Holt, would you be against the widespread testing of asymptomatic people?
Well, I think I certainly, right now, we're doing that in the long-term care facilities, and I think that's a population that we need to know. The asymptomatic testing or positive or testing of asymptomatics to the general public provides some use for the general public or public health to try to get an estimate, if you will, about some degree of the activity or how much virus is in there. It's not an ideal test to use that for. We don't have enough labs to run, and for early on, and I heard this from many of our practicing physicians, they couldn't test the people that they felt needed to be tested because they were being consumed by the asymptomatics. A positive test in an asymptomatic person in the community for me is a challenge, only because I don't know when they were infected. These tests, PCR-wise, can stay positive for 6 weeks. We've seen that. So we're using what we got, but we need better tests to really have a better sense of what is the actual degree of viral circulation at this time. And that's my opinion.
Mm-hmm. Dr. Sinnott, do you have any opinion on that? Or I will be sending you a question concerning antibody testing, but how about the last topic?
I do have a feeling about it. It's fairly strong. We do not know how many people carry this virus asymptomatically. That is, I think, essential to understanding the spread of this disease. If we were to sample 1 million people in Tampa Bay and find no one who was asymptomatic was positive by PCR, I would see the city much differently. Right now, everyone I see on the street, I am careful to avoid, and if they're not wearing a mask, I really avoid them. So this idea of how many asymptomatic carriers are there is critical to our success in isolating people so they don't spread it.
But going back to one thing, I think Dr. Holt was alluding to, the lower the disease is in the population, the more false negatives there'll be. The higher the chance that the disease is in the population, such as nursing home, the more accurate the test, something like that?
Yes. We have to assume that the PCR, if done correctly, is quite accurate if it's positive. If it's negative, you have to think sampling error, transportation error, wrong swab, wrong test, blah, blah, blah. If it's positive, that virus has been there. I look at it as a fingerprint at a crime scene. It's either been there or it is there. The next step after you identify people with positive PCRs is much trickier. We have to see if we can culture live virus from these people. And that is sort of the holy grail of this. If the people are PCR positive and have live virus, then we know what's going on in the population. When you test for antigen, there are many problems with contaminants. Like I used to say, the influenza antigen test was wonderful. You can have your choice. It's 50-50. It's 50% sensitive and 50% accurate. It's really not used. I think it's going to be the same way with this virus. Long term, there's antibody testing, which would tell you exposure to the virus, but it will not, at our current state of knowledge, tell you if you are immune or not. But that also would be valuable information. We may have had twice as many cases as we think when we start doing that testing, which would tell us that the disease is milder. I don't think that will be the case, but that was going to be a delightful finding.
Yeah. Along the lines of testing, and we all read the data that comes out every day in our whatever newspaper we read, as far as the data globally or the data in our nation. And it seems like the United States seemingly has a disproportionate percentage of the world's COVID #1 infections and deaths. Do you feel that we're just keeping better statistics, we're testing more people, or is there something that makes us as a population more vulnerable?
I suspect a few factors. It's becoming more clear that there are at least two strains of this virus. One is the original Wuhan strain, strain A, although I have no proof. The clinical course of this is much more consistent with what happened in Wuhan. Strain B, and I remember that as B for bad, apparently mutated in Milan and then found its way to Italy, Spain, New York City, and from New York City to Miami. This strain replicates about 270 times faster than the Wuhan strain. That accounts for these massive coastal outbreaks on the East Coast. This is from Europe. The other issue is that if you're going to engage in isolation, you're dealing with logarithmic growth. 2, 4, 8, 16. Only you're not starting with 2. You might be starting with 600. And that is the basis for socially isolating people. Not that we'll totally eradicate the disease, but essentially hold it at bay until we have a better prevention or some sort of therapy. If we could treat it with something akin to 500 milligrams of penicillin a day, that'd be great. The fear would be gone, the economy would be back, things would be fine. But it'll be a while till we get there.
Okay, so you mentioned travel from people from both the East Coast and West Coast was part of the higher numbers. But don't you feel that our country has more accurate statistics and are testing more people? Or do you not feel like that's the case?
No. South Korea, when I last checked, was testing more people a day than America, than the United States. And I would give you an example. Right now, China has announced that they're going to retest everyone in Wuhan, which is 11.5 million people, and they're going to do it in 5 days.
Okay, wow.
Different government, different country, but they obviously believe in testing. The primary unit of spread is as a family cluster. Someone goes home, gives it to their family, and then that family spreads it out to other people. And that emphasizes the importance of a mask so you don't take it home to your family.
Okay.
Yeah, I think you have to look at the per capita. I mean, if you look at all the tests compared to the population, we haven't tested as much as many countries in the world. And again, the same thing with the relative number of cases per population. You have to adjust for those. This virus was in the United States a lot longer than we knew. It spread, and New York City is a disproportional amount of the infections that we've had because it is an environment that was just highly conducive to the spread.
Okay. Dr. Holt, can you comment on the CDC's recommendation of a 14-day decline in cases that need to occur in a particular region to allow that region to open up? And then just explain what that means. And then furthermore, talk about what are some of the possible theories as far as reactivation and reoccurrences of say, peaks in the upcoming months? What's the possibilities of those?
Sure. Yeah, the 14-day trajectory, really is designed to correlate to the incubation period of the virus. So what you're looking for is, as Dr. Sinnott taught, the logarithmic growth. So you look at what's happening over that 14-day period. It's really, I guess, there's a term that we use called R0. It's the amount of virus that how many people one person infects. So if somebody's infected, how many people do they infect? So this is kind of, I looked at it as like our community, how many people who are infected, the viral load in our community and how many people are they infecting, which correlates with how well we're social distancing, how well we're trying to prevent that spread. And so, from a simplistic standpoint, if you think about it as a wildfire, so if we're seeing the trajectory, 14 days, increasing significantly, about a 5% or more increase, then we've got an uncontrolled COVID outbreak. If it's flat, or even if it's increasing but not dramatically, then we're gaining control. It's not exploding. And what we're really looking for is decreasing, and if we can get it to where it is being reduced by a significant, then the fire is under control. But very important to realize it's still there, it's still smoldering, and it will come back. And I think that may have been part of your other question, is that we will see waves. We're actually not even out of the first wave. I think that's a misunderstanding. We may be hopefully on the tail end of it, but it's certainly still here. And then history would suggest, if you use influenza, that we're going to have a 3 to 6 month lull. And then the second wave has a potential to be significantly larger than what we've dealt with. But we can control that. We can influence that if we continue to adopt the habits, the situational awareness, the sensibility of how we live our lives, and at least minimize the size of that second wave. That's kind of my thoughts. I don't know. Welcome Dr. Sinnott's viewpoints.
I agree totally.
Okay, I have just one more question that was submitted previously, then we'll have some time, it looks like, to answer some of you viewers who have sent in some questions, some very good questions during this town hall meeting. So even if widespread testing becomes available, so we know the status of this person we're walking down the sidewalk with, or the person next door, do you foresee that we in the Tampa Bay area can return to some type of new normal? Is there any timeline for that? And if and when do we feel like things like sports teams, sports events, concerts, parades, and Super Bowl can happen again? Dr. Sinnott?
Well, humans by nature are social animals, and this virus preys on that unique aspect of being human. I like to say that in a way it's like 9/11, but much worse. There was a time before 9/11 and a time after 9/11, and they're not the same in any way. This is going to change the way people look at infectious diseases. It's going to make them much more cautious about ill individuals. The fact that this can recur suddenly is always a threat. There's a threat it could mutate. And also there's no guarantee, given the unfettered randomness of the evolution of these viruses, that we can't have a second virus totally unrelated to this develop next week. I tend to be very cautious. We had three, if I might take a moment, we had 3 early warning systems a few years ago. We had the pandemic preparedness team. We had a CDC that was funded in 2016 at $14 billion a year. This year it got $5 billion a year. So it's no surprise they can't get out a good test. All the senior people left and went to other jobs. Also, there was a PREDICT program, part of USAID, whose job was to identify new viral threats. And they were quite successful. They identified the Ebola outbreak of 2016. they helped identify the SARS outbreak, and the dismantling of these programs have left us vulnerable.
Dr. Holt, I promised I'd come back and ask about antibody testing later. And as far as antibody testing goes, is there any purpose or place for antibody testing at this time other than testing past infectious people to see if their plasma can be used for treatment? And if not at this time, is there a place for it in the future?
Yeah, I think there is a place in the future, but right now, I personally would not get tested with an antibody. Certainly none of the ones that are out there right now commercially available. And if I did, it would be a blood draw, not a finger stick. I think that definitely not to be done. With time, I think it will be useful for the public health prevalence, looking back, getting an idea of just how many people have been exposed and infected, assuming that we're dealing with an antibody that is specific to this virus and not some of the other coronaviruses we have. Long term, if we can figure out exactly which one is neutralizing or protective and a vaccine comes along, a test that almost like we do with hepatitis, we can test for response if this is correlates with the immunity, and that's not been that's certainly not the case right now. But that's my hope, is that would be coming eventually.
I've only myself used the test once. It was a pulmonologist who worked with COVID patients that developed myocarditis, which is a late recognized complication of this virus. And it wasn't so much for medical reasons as for workman's comp and disability. He was negative on antibodies, so whatever myocarditis he had, I did not feel was attributable to COVID. But that's the only time I've ever used it.
Yeah, Mike, if I, on a personal level, if I did get tested and I had a positive antibody, it really wouldn't change my behavior. I certainly wouldn't feel comfortable now going out and hugging my 87-year-old grandparent, my mother. So you have to be cautious that it doesn't give people a false sense of security, or even certainly the immunity factor that I mentioned before.
There you go. So it does not indicate immunity for sure. Okay. In the nation, any asymptomatic patient who tests positive, are they counting that as a case?
Yes. Yeah. If tested with the PCR, positive antibody is not recognized as a determination of an active or a proven case.
Okay. And then Dr. Sinnott, if an asymptomatic person tests positive, does that for sure indicate that they're infectious?
People do not know. We believe that it does. We believe that they're contagious for 8 days after the onset of symptoms. That much we know from studies. People that show up positive have not been studied. It's a very dangerous virus to work with. Have not been well studied, but those studies are underway. It sort of breaks my heart to have someone and say, gee, you're PCR positive, but I really don't have any medication for you. So we have several studies involving everything from nitazoxanide to hydroxychloroquine to other agents that are experimental, like N318, whatever that might be.
Okay. A few more questions from our viewers. Can an immunocompromised person safely take the vaccine when it's available? Probably put in another way, what will it take for a vaccine to be safe in our highest risk patients?
It would have to be not a live virus vaccine.
For sure.
Yeah, and I think the other corollary of that is that our most immune or most vulnerable or our lower immunity maybe need higher doses and some others to achieve the same level of protection, which we already see with some influenza vaccines.
Here's another question. I'm not sure if the Hillsborough County or the state of Florida Health Department does this or not. We see basically numbers of cases and numbers of deaths. Is it also public record that we'd be able to see these broken out by age and other comorbidities? Is that public record already?
Age is a public record. Actually, the medical examiners provide actually a much probably more in-depth description, and you can you'd have to look at it on an individual basis. I think is the challenge on your comorbidities. I can tell you that for the first 40, I haven't done it since, but that was what I was committed to. Is I go over each case with the medical examiner here, and you know, they're all highly vulnerable. Age is extraordinarily. We've had one person die in this county under the age of 55, and that individual had significant comorbidities, because I think we all know age by itself does not mean healthy, younger. So that is the one thing we pretty much know for sure, is that this virus is deadly in our elderly and those that have chronic medical conditions.
If I could take that one step further, to me, the absolute mortality is almost like a wartime statistic. It's like body counts from Vietnam. You really don't know what they mean. I think it's much more important to think about the long-term side effects of infection, the sequelae. I actually went and treated SARS patients in China 17 years and 2 to 3 months ago as a consultant. I returned at 5 and 10 years, a very similar virus. And 1 out of 6 of those patients, of the survivors, were on oxygen when I returned. 1 out of 8 needed 1 or both hips replaced. 1 out of 16 had neuromuscular weakness, required a cane, a walker, or a wheelchair. And I think I was most bothered by 2 doctors that I saw that could no longer do their job. And when they got the Chinese version of the Stanford Binet IQ test, they had IQs of 95 and 96. And they certainly didn't start out at that level. So we don't know what the long-term effects are. And I think by looking at the death rate, we do ourselves a disservice. We say, oh, it's 1 out of 100, it's 2 out of 100. Well, the complication rate with this is totally unknown.
Another question from the viewers. What will the experts look for, and we're talking months down the road, we know, what are they looking for that we can return to standard universal precautions in our offices?
What, when you, that's a tough question. I think there's going to be a modification for a while of what our standard universal precautions are.
There'll be a
Number
modification.
one. Number two, and let's be frank, and Dr. Sinnott is the epidemiologist of the hospital. We as professions sometimes aren't the best at prior to Corona for practicing standard universal precautions. So I think if we improve that, if we can do that, we're adding a lot. The heavy use of N95s in your offices and others, certainly add an additional layer, but everything else is more important leading up to just that one piece of equipment. So, but I think with vaccines in the future, we'll get closer to what the new normal is, or the new normal of what we used to be, our normality, I think is how I would phrase it.
If I could tag on to Doug's excellent observations, we're currently working on building a COVID hospital at Tampa General. Now, part of that is going to be intake, and in it, we're taking patients with respiratory symptoms. And recall, not all of the COVID patients have respiratory disease. We're going to screen them separately in a negative pressure area and then decide on their disposition. So what would I do if I had a private practice as an ophthalmologist? I would make sure there's alcohol, hand wipes. I would have someone greet them at the door with a thermometer, get a temperature. Temperature is a very sensitive indicator. And then the next question is, which can get the infectious disease doctors in a fist fight, is what is a temperature? So to me, it's 100 degrees. It's pretty simple. I'd alter the traffic flow in my office so that people were not meeting face to face, either my staff or the patients. They would go in one door and out another. I would provide a mask at the door, or I would tell them before I accepted an appointment that I'm not going to see you. I'm not even going to let you in the building if you're not wearing a mask. The mask is extraordinarily protective for other people. An N95 would protect you, but a surgical mask does its job. It protects other people. It's almost an act of antisocial behavior to me to not wear a mask these days.
Okay.
If I may, I actually had an interesting experience. I went to my dentist today, and that was a new normal. They called me in advance. They asked me if I had been around anyone, if I knew anyone that had been sick or certainly had been even tested for coronavirus. And I did get my temperature checked at the door. The waiting room is clearly appropriately placed, and every one of their staff was wearing masks. And of course, I had to remove mine for them to do their job. And I think I felt comfortable with the experience, except it hurt a little bit.
Okay. Any comments on infrared thermometers as a method for temperature?
I actually would like to, can I take that one, Doug?
Yeah.
They're excellent. It's very important that they calibrate. When we buy them, for instance, we purchased 60 at Tampa General the other day, and I always have a very conscientious person compare them. I'm not using these on people because they're so non-invasive, but they're mass produced, and they're supposed to be sensitive to 1/100th of a degree, and they're made to a low price point. And sure enough, 2 of the 50 read artificially low. None of them read artificially high.
They need
So
to be calibrated though.
the 4%, well, a comparison. And I sent them down to biomedical I said, can these be calibrated? They said, no, throw them out. Just toss them out. But you have to recheck them. They can be dropped. Batteries can be low. They're not maintenance free. If you test them on yourself, you're normal. Check the batteries. Don't let the batteries get low. If you read the directions carefully, many recommend lithium batteries as they don't leak and they're more of an on or off, whereas the alkaline cells have like a gradual deterioration. So sometimes you're right and sometimes you're not.
Okay. In just a minute, I'll be asking you for your final thoughts and it's sort of like a take-home message to our viewers. Many of the questions that are coming across are asking you guys to predict the future. And I know that puts us in a tough spot and it was hard to prepare for the question. But here's one particular I saw interesting. And then after that, I'll have each of you give your final parting words. The question is, does either panelist see a future in which PCR testing will be used for things like cruises, sports events, concerts, or entry into other group activities, or antibody tests be used for travel usage, such as, and even some passport marking? Can any of you think?
Do it, Doug.
Sorry, say it again, John.
I can answer that, or you can answer that. Which would you?
I will give you the first shot at it.
Go ahead, Dr.
I definitely see that. The pressure's on to have a rapid saliva test that's accurate. If there was a rapid saliva test, I would be comfortable going into the Bucs Stadium and not worry about it. If I saw everybody spit in a cup and do whatever that test might be, that'd be great. And had their temperature checked.
They'll tack that onto the price of the ticket, I'm sure. Okay.
Triple that, of course. So I think that's essential. The idea of going, I'm actually going to some of the oceanographic research vessels tomorrow to get them sort of in the mind that you're not going to be going on any 14-day cruises without screening everyone before they get on the boat. Then they stay in their hotel room and they come right to the boat. I think that would add a lot. Anyone would agree to that. That will be the new normal. Now, if the antibodies we can show are protective, that would be nice to have in your passport, but we don't know how long they're protected for. Most coronavirus antibodies of the known agents only lasted most 18 months.
Okay. So there would be a timeline, even if it was required. Dr. Holt, any of your thoughts?
No, I concur. I mean, I think we will advance the technology of testing. It's amazing, really, when you see how much we have done in a relatively short time. You can do some of the other, how long it took us to get an HIV test and some other tests that really are refined. And there's a lot of incentive to get that test, those types of refined tests. But right now we have to live our lives with what we have. And, you know, we still have a lot. We should not be afraid to make sensible choices and decisions and, you know, do what we find that balance between, you know, getting out there and getting back to don't like that normal term, but certainly back to a life that we can enjoy. It's been a tough couple of months.
Yes. One last question on that, and then Dr. Sinnott, I'm going to ask you to give your parting words here. Dr. Holt, what you just said then, if one is outside and social distancing, is a mask still an appropriate? Of course, it could be appropriate, but is it a have-to thing if you're social distancing and say walking on the beach or walking around the block?
Well, I would say, you know, how did you get to the beach? You better have a mask. You should have a mask available. You don't know what you're going to encounter. But certainly in the right scenario, right situations, I will put my mask aside and enjoy the beach, if you will, or somewhere.
Enjoy breath fresh air.
Distance is important. It is the critical in being outdoors. It's a lot of advantages, but again, I would say, how did you get there, and who are you around, and what are you doing?
Or just stop along the way.
And that's more important. Okay.
We appreciate both you guys for giving us your expert opinions and sharing the data and information. Dr. Sinnott, is there anything that you would really like our viewers to take home as a strong message today?
I would beg all of us as doctors, as role models for the community, as the most respected group in America, to set the standard of wearing a mask in public. Why? You're protecting other people, and that's our role as doctors. We need to take care of people that don't know as much as we do. I can't tell you how many times I've run into people that are surprised that I'm wearing a mask, and then all of a sudden when they find out that I'm a doctor and wearing a mask, they start wearing a mask, and that will reduce cases. We're going to have, I feel, difficult times ahead. This disease is still doubling in St. Pete and Tampa every 5 weeks. We need to wear masks and show people we care.
Dr. Holt, your parting words.
I think Dr. Sinnott always, to follow Dr. Sinnott, that's a hard act to follow. I think that, and just, recognize, information and knowledge is key. And as Dr. Sinnott says, physicians, we should understand, the virus. We should be able to model the behaviors. We should be able to find that common sense approach that will keep us and our others safe. And be careful about when you're around elderly and our practices. They deserve our to be protected.
Okay, I just want to say thank you again to our two panelists. Thank you also for our viewers and those of you who submitted questions. I would just like to close by saying what we saw on the billboard today is be calm, be kind, and stay safe. Thank you and have a good evening.
Thank you, Dr. Cromer.